Yeah.
Well, thank you all for hopping on today. We don't have a whole lot of teaching to do or talking to do, but we just wanted to kind of go over a recap of this last Pace4Life trip this past end of May and beginning of June. It was fantastic, and I think it's just good to kind of learn from those experiences and share what we took away and how we can optimize moving forward. So just put a little something together. Dr. Temperley is going to be doing his own talk as well about actual procedural optimization and steps that we can do to make our procedures run as smoothly as possible. But this is more, Julius and I did some brainstorming yesterday from our key takeaways and a little bit about specific patients. So we'll hop right into it. Maybe. There we go. So we just shared a few pictures here of the procedures themselves. This is one of the BIVs that we did. This is the initial venogram, followed by, you can see the actual LV lead placement here. Looks like a bipolar LV was put into place. But I just kind of wanted to demonstrate some of the complexity that we handled. You know, we did a number of cases here. So as far as our accomplishments, we did 6 CRTDs. And for those of you who were in the room with us or familiar, obviously those are fairly complicated procedures. So to get 6 of those done was fantastic. 4 dual chamber pacemakers. We actually used BIV generator cans for this because we didn't have dual chambers on hand, unfortunately. So we had to do a little bit of finessing by actually taking a BIV, plugging the LV port and utilizing it as a dual chamber, which in some ways is beneficial because you get a little bit more battery life out of it, which is fantastic. Let's keep moving here. We also did a CRTD box change, a lead revision, 2 ICDs, and then we did 2 ICDs in Lagos as well. So yeah, it was a very productive week. We saw 2 patients in Abuja clinic in addition to the patients that we saw, post and pre-operatively. And then Julius and Elvis went down to Port Harcourt with Dr. Dafe to address 69 patient clinic. So that was a very busy day for them. And I think Julius can kind of speak to that. I don't know if you wanted to jump into any of that, Jules, or we can just move on and
just move on.
Yeah, okay.
But you said it all. Yeah.
Perfect. So yeah, these are some of the teams, some of the teaching. Obviously, here's Elvis running the show right there. You can tell from his green hat. Here's Julius in Port Harcourt. We've had 2 programmers running. Obviously, I didn't want to show any patient faces, so we got the back of the head here. But trust me, he did see a lot of patients that day, as everyone can testify. So here's some of the time we spent in Lagos. And then some of the procedures that we did with Dr. Temperley and Dr. Dafe overall experience. I want to go ahead and talk about some of the benefits we had here. We were very impressed with the staff. Everyone was very dedicated, and we worked a lot of late nights, and there was no complaining. Everybody was just ready to put in full effort, which was fantastic to see. Obviously, we had very experienced cardiologists that were ready to train as well as share their own experience. And I think that having someone who is experienced in this field is really beneficial because they can add some of the knowledge that we don't have coming from overseas, and we can kind of combine our resources and our education. Having strong interventional programs have translate to CRM success. Just from our experience in Lagos and Abuja, having a lab that's already set up and ready to go, especially having a quality fluoro equipment and things like that, really translates to us being able to just roll in and start addressing patients right away. We're not using any kind of like C-arms or anything like that. And it's good to have staff that are ready to support if we have any kind of complexity. There was a good commitment to sterility and safe practices. We'd love to see that. So we were very impressed with, the facilities and how well everything was ran there. So it was great experience for us overall there. And then one of the things that was very impressive is just the collaboration amongst institutions, amongst physicians, and the national, and then obviously cooperating with us as international foundations. You don't always see that when you go overseas. So it was great to to have that kind of support where we knew that everybody had each other's backs and we're all trying to do the best we can to serve, underserved patients or indigent patients that otherwise wouldn't receive therapy if it wasn't for these organizations. So we really appreciate that. Overall, so there were some challenges, obviously, and that comes anytime you're traveling a long distance to cover cases. Medicine effectiveness and quality control issues, I think that some of these things can be reviewed, and I think that it just needs to be taken into account. And I think we had a little issue with our local anesthetic, but we quickly audibled to other medicines or other therapies to kind of compensate for the lack of local. Programmer availability, we just don't have a lot of programmers, but Pace4Life has worked, and with Julius especially, has worked very hard to get those new Medtronic iPad-based programmers available. And then obviously we're working on getting more programmers for St. Jude as well. So as we get that, it'll only be easier to support our patients and support more cases in the region. We did have some.
Just a question on the local anaesthetic. Is it a good idea we should be bringing our own? Is that like an issue? Like the patients have to pay for it, do they? We should just bring loads of our own, should we?
So we actually mentioned, that's a good point, Joel, and that's one thing that mentioned later is I think it's not a bad idea, and if we don't use it, we can leave it behind for them to use later, and it'll only help with cost savings. But if we do need it, we don't have to give so much fentanyl instead, to have something that works. Because one of the problems was they didn't seem to be responding to it, but you can't just continue to give it, because if it is actually legitimate, we could be causing neurological issues. There could be some, not ideal things for the patient. So I agree. I think it's good to make sure that we have it and bring it in.
Are you actually saying that you used some and it didn't seem to be working?
Yes. So for the first couple patients, we thought maybe they were just a little, just not experiencing the best time, because it can be a little strenuous and stressful of a situation anyway. But by the third patient being fairly symptomatic to even light touching of the pocket, we started to determine there may be something going on with the local. So
wow.
Quickly, I don't know, I'm not a physician. Dr. Dafe, you can kind of maybe shed some light on what we did instead. I think it was a fentanyl, or Tara, you were there as well. So I don't know if anyone wants to talk about the cocktail we ended up using.
Was it propofol?
Yeah, we used midazolam and fentanyl
instead.
Okay.
Okay.
And there's
and
a question.
Well, I had to use propofol a couple of times as well.
Yeah.
We had to get an anaesthetist
So
involved.
yeah.
But for a future mission, would you take just bupivacaine with adrenaline, or would you want fentanyl and midazolam? That's obviously a bit more difficult to transfer. You'd want all of that, really.
Yep.
We used bupivacaine and lidocaine at Northampton.
Yeah.
So it would probably be better.
I think it depends what we can carry over. If we're going to run into issues at customs and things like that, then that may be a limiting factor. But some drugs, fentanyl might be a little harder to carry over, is my one concern.
Yeah. Can I make some comments, sir?
Yes, sir.
Yeah, very good. Thank you very much for bringing up the issue of the local. There are many issues, like I told Dr. Timpley, when this matter of the local anesthetic came up. I said that there are many issues why some of these locals behaves the way they behave. One is that studies have shown in our environment that the temperature we have here really affects our medications. That the optimization of the medications that you have in temperate region, in low temperature region, when you come to the tropical region where the temperature is always high through the year, the effect of those medications is not as optimal as it is in the temperate regions. There have been several documentations on all this. That is one. Then two, we know that this is a developing country, and the issue of fake drugs over entering into the system is very high, because the authorities don't really push or monitor them effectively. and you can get parallel drugs or drugs that are suboptimal, and something is written, maybe paracetamol, 500 milligram in a tablet, but when you actually go to the chemistry lab to go and check what is actually in that dose of that drug, it may be maybe 350 or 400 milligram. So, but what is written is 500. So these are all the issues that affect the issue of a drug here. So like when that matter came up, the first patient we had during the, that was the first day I remember we did 3 CROTD. Now the first patient, we didn't have much problem. And then we also noticed that in our African patient, when you give them midazolam, they usually react, they usually become hyperactive, they react very funny to the drug. But that is why when I, because of that, when I give, when I'm doing CROT, if I give the local, I don't traditionally use midazolam, but we get the anesthetist at the corner so that if there is any need to escalate, the anesthetic comes and take over while your procedure runs smooth for you. So that has been the strategy that we use here. So when we took the first case, we didn't have much problem. The second case, not much problem. When we started seeing the issue of this local and this thing, even there was 1 or 2 cases where we have to not get in the anesthetist to come and sleep up the patient for this issue of patients having pain and the rest of them. So there are varieties of issues that affect the dosing of these drugs. As AJ rightly said, when you give the right whatever they prescribe dosing, if the patient is not responding, you cannot go further because you feel that you have given the right dose. And if you go further, your heart will not allow you to do that, your conscience and your practice of medicine will not allow you to do that as a medical doctor. So the next thing you have to do is to escalate the matter to the anesthetist to take over, and you allow your procedure to go smooth. So this was how we run the program for the remaining cases that we're having this issue of the local. So it's something that do occur from time to time, even in the cath lab. Not just only that, when you give local for maybe for your angio for access, it's similar thing that you also experience here. So as Dr. Joel suggested, if we come with some sample from the UK, we can test those samples and see their response against our local here. Then that would be a background for us to say, okay, for future mission, when you are coming, get some local. But for the issue of propofol, I will say no because of the issue with the custom, so that they don't go and pick up something under their scanner and start searching you more than what's supposed to search. Propofol, for you to use propofol, the anesthetist has to be available on the ground, and it has to be the work of the anesthetist, not the cardiologist or the surgeons to prescribe it in the absence of the anesthetist. Our propofol, we have never had any issue with it. Fentanyl, we have never had that issue with it on the doses that the anesthetist use. So once we escalate to that point, we call the anesthetist and they took over that, and we just continue with that procedure and end it there.
I really appreciate that. That's fantastic. One question. So you mentioned the temperature. Are you saying the temperature that the drugs are kept at, or is it to do with the patient themselves? When you're talking about temperature interference? Dr. Dafe?
Yes, the temperature that the patient makes down. Can you hear me now?
Yeah, I got you now.
Yes. So what studies say is that the temperature we have here makes the drug ineffective. It reduces the potency of the drugs compared to what is being used in the temperate region. When I told Dr. Timpley, what he said is that, what about if we keep them in the cold chain? So he said that what of the lab that is cold? I said no, that the lab is cold doesn't mean that the drugs are cold. Before the drugs get to that lab, they have passed through the pharmacy, through storage and other things where the temperature are very high, and that reduces the potency of the drug. So by the time they get to the cath lab where you put them in the fridge, they may actually behave as a reduced potency because they are passed through that high temperature in the process of passing through many chains to get to the cath lab. That was how I answered the question to him.
Gotcha. No, that makes total sense. So Dr. Jalen said in Kenya, they use 20 mil of 2% lidocaine. In Northampton, they use 10 of 1%, just for reference to everyone. He mentioned that the tougher skin can also affect, making the pocket. So
yes.
Who else here?
Then the other thing, AJ.
Yes.
AJ, sir, the other thing that we also do here is that when we notice that the patient doesn't do well only to lidocaine, we combine it we mix lidocaine with bupivacaine and the normal saline, that is tumescent anesthesia. The way we mix the tumescent anesthesia is we give 15 mils, the way we measure it, 15 mils of lidocaine, 10 mils of bupivacaine, 5 mils of normal saline. We mix it together. And when we do that, it's more effective than giving only the lidocaine. That is another experience we also have here.
Okay. Yeah. Dr. Chigozi asked about 7.5 mil lidocaine, 7.5 mil bupivacaine, but you're actually doing a higher lidocaine. You said 15 to 10, correct?
Yeah, 15 to 10 to 5. To 10. You missed 3 things.
Okay.
15, 10, 5.
Okay, perfect. All right. Let me get back here. Let me close out the chat. So we talked about medicine, program availability, supply. So we had some supply shortage issues. And I think part of this is, obviously it comes with, we can only carry over so much. And I think that in future trips, we'll be able to carry over more and send more ahead of time. But we did have a shortage of accessories. So port plugs, especially, we ended up having to sacrifice some bipolar leads to plug ports so that we could use BIV cans as dual chambers. I think we also did that with one of our, maybe one of the CRTs as well to make a dual chamber ICD. We didn't have any dual chamber pacers, obviously. Caps are also nice to have. So instead of cutting off the lead and tying off the insulation, it's nice just to have a simple cap to cover anything that we have clipped or any kind of abandoned leads. We had a shortage of PSA cables as well. So as you can see later, we had to do some adaptation with our PSA cables. Stuart and I did a little bit of wiring, but it worked out pretty well. Leads. So we had a shortage of leads on hand as well specifically for Brady. We had no shortage of LV or the high voltage leads, but the cheaper leads we didn't have a lot of. So we had to kind of adjust our strategies, and we'll talk about this later, but in some cases where you only have shorter leads or you have more short leads than you have long leads, and you have a list of patients, it's always recommended to maybe try the shorter 52 centimeter, for example, in the RV. And if it's too short, adapt that to the A. So it's a way to kind of to preserve any of your longer leads you may have. We found a passive fixation 60 on the shelf. And by our last case, if that 52 did not fit in the RV and we had to just put it in the RA, we would have had to use an 85 CM RV lead, which is a lot of extra pocket bulk. So I think next time, obviously, we'll try to have some more Brady leads on hand and ready to go. Once again, we mentioned dual chamber pacemakers, external defibrillator. There was not an external defibrillator in recovery. So at one point, when a patient started to code, they had to grab the defibrillator out of the room we were doing the procedure in, which is also our main source of EKG, and run it out to obviously give therapy to the patient who is coding on the table. But that kind of leaves us blind in the room. So I think just proliferating external defibrillators, especially in holding and higher risk areas, is going to be important. And I think that that's something that Joel, you've obviously been working on. We brought one over with us this past trip, and we're going to continue to acquire those devices and get them widely available.
Yeah, just in response to that, we have 2 more defibrillators in the bat cave. We have, I think, a load of PSA cables as well. We just didn't bring them because we didn't think they'd be useful. And we've got an absolute pile of leads. So again, when Pace goes out to his next mission, we come back out again. I think we need to get more variety out there, or even send a shipment. So there's a bit of a supply, don't we?
Yeah. Then in addition, Dr. Joy, you sent 2 defibrillators to me, one in Abuja, one in Port Harcourt. So the one that is in Abuja, one of the battery, I showed it to Julius. One of the battery have some issue, but you can plug it and it's still working. So that is what. After the mission, we noticed that because during the mission, one of the patients that we did earlier on had multiple VT. So AJ, Julius, they have to move out to attend to that patient while Timpley and I were on a procedure. So what we did after the procedure was to move that the defibrillator you sent to Abuja, to move that into the recovery room. So currently that defibrillator is stationed in the recovery room, in addition to the studies that we are using it for.
Okay, so we need to send you more defibrillators.
Yes, sir.
And
yes,
do you need more pads? Do you have good access to pads? Because we only sent you a fixed number of those.
No,
but is that a problem?
We don't have access. Yeah, we don't have access to pads because all the defibrillator, they use pads. They are not Philips defibrillator. They are not paddles. These not paddles that can be stationed permanently. Is pads. So we need pads, as AJ pointed out. We have some here, but I'm sure when those expire, when those exhausted, we may need more to get on.
They use a lot of the conductive gels, Joe. So that's what we use to defibrillate that patient. So they don't have, for instance, like if we're doing an ICD implant for a patient, whether primary prevention or secondary prevention, so we would have a pad on in case anything. So they can't afford to do that. They can't afford to do
that.
I just couldn't find any paddles. Yeah. I was looking for paddles to send, and literally they're so old that you can't find them in the UK at the moment, but I'll keep looking.
Yeah, pad will be fine, sir. Pad will be very beautiful. Yes, sir.
So the one thing we mentioned too, EKG quality. So there seems to be a little bit of noise on the EKG in the room. And I think that may be just a result of having all this equipment that may not be fully insulated. We see this all the time in the US as well, is if there's not an insulated plug, that can cause noise both on the device when you're interrogating it with the programmer. It can also cause noise on the EKGs. So just making sure we have a quality EKG system. But the real reason I would say is the 12 leads. So I think we had a good way of doing 12 leads, but the systems weren't very good at doing like a live 12 lead where we could optimize. It liked to do a screenshot that would take about 2 minutes to take a picture, and then you get the 12 lead pushed out. But unfortunately, when you're trying to optimize LV-RV offsets and all these different variables for biventricular pacing, it's good to have just a live EKG that you can pause and freeze. So recording systems obviously would be useful. And then down the road, as we work on getting electrophysiology like EP ablations, recording systems are obviously necessary. So working on that, I think would be helpful both in holding, but also in the room. Patient prep and turnover, as Dr. Dafe mentioned, I think that we saw patient prep and turnover a little slow for the first couple cases, and then we saw an immediate speed up over the following days. And I think that's just a volume thing, right? You don't do a certain procedure very often, and it takes a little bit of time to get that down. But then once we were rolling, the turnover was incredibly fast. So I would say for future trips to other locations, I would just trying to prep the patient for the next case while we're still in the previous case is usually, it's more conducive towards a quicker turnover and getting 5+ cases done in a day, which we were doing by the second day. So just a note. Power cuts and generator delay, these are just complaints. It worked out fine. They have a backup electrical system for both the programmer and the light. So we'd only really lose the room lights when the power went down, but that's just something to be aware of when you're traveling. And I would say if you don't have a system as robust as they had at CardioCare or FCC that has backups in case the power goes out, be ready, because if you don't have batteries in your PSA and that patient is dependent on pacing, you're going to have a bad time. So make sure you have your backup batteries in your PSA ready to go, just in case we lose, full power to the system. But that was never an issue for us because of what they had in place. Disposable quality, honestly, disposables were good. Drapes were fine. The one problem was the gowns didn't seem to be well constructed to maintain sterility of the back. So we had to do a lot of taping and just being aware that you have a unsterile back, so you don't walk backwards into the table, or you don't walk backwards into one of the other physicians and now they're no longer sterile. Making sure when you cross each other in that tight corridor that you're crossing back to back, and just being aware of the challenges. It would be nice if we could bring some better gowns for these more sterility, in a cath lab is different from sterility in the EP lab. And since we're leaving something in the body, we definitely don't want an infection. So anything we can do to optimize that and bringing.
So we bought all the drapes, didn't we? Specially, but is that your normal drapes, Emmanuel, or did we use something special?
Yes, very good that the question is raised. The Pace4Life bought all the drapes that we use for the missions. Those drapes are the normal drapes that surgical drapes that are being shifted to Nigeria. So we are not in position to control that, because even those drapes are not manufactured in Nigeria. I think they are either manufactured in India or in Thailand, and they shift them, or China, they shift them straight to the country. So we just buy them and use them the way we met them, the way they are. So very important point to raise, sir. Hello, sir.
Sorry, I was trying to unmute myself.
Hello.
Dr. Daffy on that. So I think the drapes themselves were great. The only thing that really was concerning, like I said, were the gowns, but I think we figured that out. But I think it's just something to be aware. I'm not sure the gowns, we didn't source those. Those were local, correct? Did we bring those over?
The gowns, AJ, can you hear me? The gowns and the drapes are all sourced, bought here locally. It's Pace4Life paid for them, and the hospital bought them locally. So the local source of these drapes, even though we buy them locally, they are not even manufactured in Nigeria. They are manufactured outside Nigeria, like India or China or Thailand, and they ship them to Nigeria for sales. So this is where we get them from, sir.
Okay. Yeah.
Can I just add? We took a few gowns from Northampton that were donated, like just a handful that we took, which is why it was really tight. They were all large sizes, so which is why it was quite tight to fit around, JT and also Dr. Daffy at times, having various sizes. But yeah, it would be definitely good to, in the future, for any future missions, to take gowns as well. I think that would be a really, really good thing.
Yeah. Then the other thing I still want to say is the sizes of the gown. And maybe if we're even buying locally, is for us to request for extra large. That is the surgical gown. Yeah. So because the gowns, you pay for surgical gowns, and the supplier just gave you maybe medium or small size. When you are wearing it, you will have issue at the back. So, but if you give instruction to the supplier that please supply me extra large, extra large, and medium, and it mix them up for you, you will be able to sort out this issue that Mr. AJ just raised about the back of the surgical gown. So I think that is, we need to work on that. for future mission. Even though we are getting them locally, we have to give that instruction that to the supplier that they have to give various sizes of the gun so that we know who is coming and what size is that person that fits that person appropriately.
I mentioned the PSA cable. So here's the PSA. They had a re-sterilizable one in Lagos. We had a re-sterilizable one as well in Abuja, but we had a ton of these Biotronic, and you can actually see the Biotronic plug here that was cut off. But unfortunately, those don't fit directly into a Abbott or Medtronic PSA. So we had to do a little bit of wiring, and then we actually made a permanent one as well that we left it in Lagos for them to use if they do come across any more of these blue Biotronic cables. They definitely function. It's just you'd have to just do white to white and brown to brown wires, tape it together, and it works, but it's just things to be aware of when you have shortages. And then there's always the re-sterilizable option, but I think that, fresh PSA cables are ideal if you can do it.
Yeah, sorry, AJ, sorry, this matter you raised, yeah, ordinarily during implants in Nigeria, we usually use, not just only Nigeria, the sub-Saharan Africa, because when you say Nigeria, you are talking about West African sub-region, Ghana, then you go to Central and East Africa. In East Africa, you have Kenya, you have Rwanda, Uganda. So most of the PSA cable that we use here are re-sterilizable because Medtronic has because dominant company here that does the local supply of pacemakers and cardiac devices are Medtronic. So they don't have enough PSA cable for every center. Then two, if you add the charges of every new case, you want to use a fresh PSA cable, even the patient has not been able to buy the pacemaker, then you want to add another charge to it. That is before we knew Pace4Life. So when Pace4Life came in, the issue of PSA cable has actually improved dramatically here. For example, now we have an adapter where we can plug it to either the Medtronic programmer or the St. Jude programmer, then be able to connect the PSA cable to that adapter. It is the first time we are using it in Nigeria is when Julius visited last year, and when you now came, that was where all these things start flowing in this part of the world. Then the other thing, so which also show that there have been tremendous improvement on the PSA cable by the coming of Pace4Life, trying to helping indigent people. Then the other issue is the issue of the programmer. Programmer that we usually use here are the old programmer, and we have not had any knowledge or seen or used the new iPad for the first time in history. Jelian Mohammed Mo Jelian is here. He is from Kenya. He's in the group. He can also testify to it. There is nowhere in the sub-Saharan Africa, especially this West African sub-region, where we have this Medtronic iPad Smart Link.
Yeah.
Yes, Smart Sync. And so this is the first time in history of this part of the world that Pace4Life made it available to us free, that we now have two smart sync, smart set Medtronic iPad to interrogate our devices. That is extremely overwhelming for all of us. One is kept for Abuja, Port Harcourt ASIS, then the other one is kept for Lagos ASIS. So it's a great achievement and a great knowledge transfer because this is the first time we are using it in this part of the world. So we must make a very significant comment on that. And we are really excited to get all this knowledge transfer that. So it's not just that Pace4Life is caring for indigent patients, but also transferring knowledge from the developed to the underdeveloping or developing country. That must be very, very important. So that knowledge transfer is what I really appreciate it, apart from caring for the patient freely. The knowledge transfer is dramatic. Our procedure and our timing of procedure has improved dramatically compared to before because of what Pace4Life has done. Then another thing again is that we had 6970 patients that we interrogated in Port Harcourt just only one day. That have never happened in our history here. The reason why that was achieved was one, AJ, Julius, Jared, and other cardiophysiologists have been interacting with us on WhatsApp call to interrogate all these patients. So the problem that we had, they have sorted it out before now. So having that number one day make it easy because most of the patients, they have no problem. I remember Julius interrogated about 5 St. Jude devices among the 6970. 5 of them were St. Jude's. And out of the 5 St. Jude, there are 2 CROT St. Jude. And he had no problem because AJ has already programmed those devices. And when he looked at them, he had no issue, no problem in the alert, everything is fine. And we just have to leave it and move on to the next. And the same thing with the Medtronic, ICD, CROT, and pacemaker. So the reason why this was done because of the Pace4Life initiative. That must not be taken for granted. Then I remember last year when Julius came, it took him time to interrogate one patient. The reason being that was the first time he's seen most of those patients, and he has never had any interrogation with those patients. And another issue that was raised then was some of the interrogation that we usually have locally were not sufficient to keep those devices running optimally. So we have benefited, not just only the patient. When a device is correctly programmed, the physician who implanted that device gladdens the heart of that physician. Then also the patient also go home rejoicing. So these are the things that we must speak volume of. So AJ, continue.
No, I think that's a really good point about the skills transfer part of this is that, there's already a strong base knowledge in these programs with Dr. Idafe, Dr. Nkarno, Dr. Olameji, and the staff there as well. But I think that having the extra support for complex procedures just makes it, it just extends this beyond just a simple one patient impact, but it's an ongoing thing. And then these are the skills that you then pass on to your to the up and coming cardiologists as well that want to implant. As Joel said, it's that hub and spoke method of you create a center for education, and that center educates everyone else, and then we can help and focus on other programs that are not so easy to access. So
I'm sorry, AJ, can I add to what Dr. Idafe was saying about the smart sync as well? So this might be of interest to Mo Gillian. So what the smart sync also does, Mo, is that allows to do, I remember you were saying that for sometimes you guys struggle with troubleshooting some Medtronic devices. So what that will allow is it will allow us to actually zoom in. You can use Zoom on the smart sync. So we can do that from the UK side and actually screen share and see exactly what you're doing. So that's absolutely fantastic. So you don't have to use your WhatsApp video anymore with Smart Sync. We can zoom in on the tablet PC and actually see exactly what you're seeing. interrogating the device. And so that's a game changer as well. The SmartSync is also compatible with most, I think, all Medtronic devices, most of their CRTPs and the newer pacemakers, and they are actually in line to update with some of, I think, most of their old pacemakers as well. So that's the likes of Sphera, and that, so they will all be by 2025. I think most of the old Medtronic devices, pacemakers, will all be like compatible with that. So you'll be able to interrogate them with your SmartSync programmer. You can also use it for doing pacing system analyzer as well. So use as a pacing system analyzer as well as doing your programming interrogation, device interrogation and things like that. So yeah, sorry, AJ, carry on.
No, I didn't know about the Zoom aspect. That's fantastic. And then for the avid programmers, just WhatsApp me in and I'm happy to help with those. But no, that's amazing. So yeah, opportunities for improvement. We just go ahead and wrote some of this stuff out. I think, like I said, there's a lot of strong aspects here, but I just wanted to kind of bring some up. So accessories, we need to, proliferate more accessories across these different labs, PSA cables, port plugs, lead caps. I also like to have suture sleeves and medical adhesive because it's a good way to repair a damaged lead without having to revise the lead itself. So I usually always keep something like that on hand, which I know we didn't have. For box changes, sometimes you'll see lead to lead abrasion, and rather than having to replace a lead, if it's not causing any kind of functional issues, you can cover that up with medical adhesive and a suture sleeve, suture it down, and it's a in the field lead repair kit basically. Additional access sheaths, we had to kind of prioritize our access sheaths that we used. And then I know that we had everything we needed, but I think it's always good to make sure we don't run out for future. So CRT tools. So I know that in talking with Dr. Johnson and Dr. Carno in Lagos at FCC, they could really use additional LV lead sheaths, catheters, wires, things like that, LV lead tools, just because it's, it can be a difficult procedure. And some of those, when you're first starting out, can be a number of hours, and you may end up going through multiple wires, or you see a difficult anatomy, you could burn through many wires. So just helping programs to have these on hand is very helpful. Equipment, defibrillator pads, we kind of talked about that. EKG machines, sterile gowns, tables. We're kind of reiterating some things here. Documentation, patient data tracking. I think it's helpful to have a more robust system of patient data tracking. I've talked to Dr. Johnson about this, and I know Dr. Dafe and I have talked about this as well, as we're working to get a system up and running where we can keep track of our patients, what devices they have, and history, things like that, so that when we're in clinic and we see something odd, we can see if this is a new presentation or an ongoing issue. In the meantime, we kind of showed some of the people like Elvis and the other cardiac physiologists on how to leave notes within a device. And I always recommend, I'm not sure as much for Medtronic because I'm not experienced programming it, but with Abbott devices, you can leave very specific notes about the patient. So in those cases, if you see something, I would say leave it in the device so the person who interrogates it next will know what's going on without having to try to dig through paperwork that may not exist. Pre and post implant EKGs, it's always nice to see. We had all the pre implant EKGs, but for our CRTDs, I think it's always good practice to do a post EKG as well, so we can do a side-by-side comparison. So implantable devices, CRT, we had to use some CRTs as pacemakers. We actually had a bunch of CRTDs that we've decided is probably 59% battery. It's only about 2 or 3 years in a CRTD, but in a single chamber ICD, that could be 5 or more, 5, 8 years. So there's always an opportunity, if you have the ability to plug it, is to convert these over to a single chamber. Lead link strategies, as we had kind of talked about in the call or earlier in the call, trying a shorter lead in the RV first if you have a ton of short leads, and then adapting it to the atrium if that doesn't work. Works with Brady leads, not obviously with defib leads, but that can help. So things to keep in mind there. Then we had talked, I talked to Dr. Ijoma, and we'd kind of briefly discussed this, Dr. Dafe. I think we're most valuable for these complex procedures because you're more than capable of doing all the dual chamber ICDs and pacemakers in the world, and you can do CRTs as well, obviously. But I think it's helpful to get guidance from seasoned CRT implanters, and that's probably the best use of our time, I would say. So we got a bunch done this past trip, and for future trips, there may be an opportunity to split consultants between facilities if we don't have enough CRTs available to maybe bring the entire team with staff from that hospital to another hospital to do their CRT population, maybe 5 or so, and then move to the next hospital to address their patients needing a CRT. That would allow, if you have 2 consultants, to train one to actually do the procedure and train a physician, and the other one in the control room or in the room explaining in more detail to physicians that are observing. And we get the most repetition, most volume out of these complex cases, because that's really where we're most helpful in these established programs that know how to do devices already. Obviously, if we're going somewhere that hasn't done devices, this is a different conversation. And then consistent programming guidelines. Julius and I are kind of working on this, but maybe getting together like a laminated sheet with like Brady settings for a basic programming. Obviously, this is not going to be prescriptive. This would be something that is just a guide, and you want to use your best judgment there. But just having the ability to see what may be a optimal solution for the average patient, and then you can always change it and optimize it for that specific patient. But walking through Brady, walking through TACI, because TACI is obviously complicated. And then I left a couple things with you, Dr. Dafe and Elvis, on CRT optimization. So those little flip books that kind of explain how to do that for Abbott, and we can put something together for Medtronic as well. This patient here, let's see, I just want to jump right in. This was a Medtronic CRTD. This one was kind of interesting because if you look at how it was registered for the QRS duration, 236 milliseconds, actually measuring it out, it's probably a little closer to 200. And you see here that it's mismeasuring or misattributing what could be a P wave to part of the QRS and adding that to the QRS duration. And then if you take a closer look, you'll see how short that PR interval is. Some degree of pre-excitation. This patient may have some sort of accessory pathway or pre-excitation. So just things to keep in mind when you're analyzing, a 12-lead EKG is you can't necessarily trust what this tells you is a QRS duration. Still wide, complex, and still needed a CRT. And I think he'll benefit very well from it. But things to keep in mind, you can't just trust, an automated algorithm to tell you the right thing. So here's what we mentioned about. Yes, sir.
Oh, sorry. Can I add to the 24-year-old? So as AJ was saying, so the QRS pre device implant was about 200 and something. After device implant, we did manage to shrink it down to about 150 after optimizing the device. So we have already shrunk the duration, QRS duration with the device, and the patient is doing well. He's regularly texting myself and AJ about how well he's doing. And his dressing was taken off, I believe yesterday, and is looking good as well. His wound is looking really, really good. And that's fantastic. Yeah, he's a really good guy.
Yeah. Great. And hopefully he'll respond really well. He said he's already feeling better, so hopefully, he'll continue. That's right.
Yes. AJ, can I just add something?
Yes, sir.
Yeah, good. So the QRS complex post implant from Jos, because he came from Jos. From Jos, the ECG is showing that it has shrunken to around 155, 160 from 200. Then there is another patient from Port Harcourt. I've taken express consent from all these patients. That is why I'm mentioning their names.
Okay.
Another from Port Harcourt, a lady, you remember the second day, that was when we did that case. Her QRS complex before implant was 140. The QRS complex post implant is 114. You see how shrunken it comes down. So if you look at the two ECG before and post, is very clear that it has narrowed significantly. When he came for dressing, I sent you the photo where he was talking about how he was sleeping with 4 pillows before now, and after the implant, he can sleep with or without 1 pillow. So the QRS complex before implant was 188. After the implant, the QRS complex has shrunken down to 130. So these are significant impacts. There's another patient.
Hey, Dr. Dafe, just because we're putting this on YouTube, I'm going to edit out all the names and the previous one listed as well. So just if you avoid mentioning the names, to make it easier for me to edit later.
Let me remove the names. So another patient that has the QRS complex of 182 before implant, that implant was done on Friday. So 182 before implant, and post implant is 128. So this is fantastic work that was done on this patient. So then the one that had the shock, and we have to take that patient back again, which you show the some of the EKG up. Remember the day we were doing that implant, after we finished with the implant, we noticed that the ROV lead had an issue. So we have to change, I think we changed battery, then also change the ROV lead. That was what we did there. Then we now tested again and moved the patient out, and we discharged the patient, and only for us to notice that the patient was having VT post-implant. And you went and optimized the patient. We took the patient back again to the cath lab and repositioned the ROV lead. And after you left, I will talk more about that patient. But what happened in that patient, when I look at the QRS complex yesterday, it has shrunken from what before implant, it was 170. Now it has come down to around 131, 132. So that is a millisecond. So these are very great numbers when we call them before and post implant. AJ, go ahead.
No, that's huge. You know, it's good to actually hear these, the actual data that from the outcomes of these procedures. I kind of skipped over his slide kind of quickly because I realized that his name was still on it. So I'm going to cut that out of what's posted on YouTube, even though we have our consents, just because if it's going to be widely available without letting them know. But I appreciate you bringing that up as far as the outcomes for that patient and explaining kind of the revising. So yeah, they ended up getting a new device, a new lead, and still saw the same issue. Finally, we revised the lead and saw a good outcome. So I think it was a mix between there may have been external noise being detected, and then we had very low sensing amplitude just due to it could be scar or something in his heart. So we ended up doing the revision and saw good outcomes, good sensing there. This patient right here was a CRTP. If you can see here, it says RV only down here in the corner. So this was a CRTP adapted to be a BiV. We actually implanted them with complete heart block. And then when I went to check them the next day, they had intact conduction. That does not mean that it's going to continue to be intact, but it's good to see that they did have some degree of recovery. So one, it's better for the battery. Two, you know, it's always nice not to have dependent patients, but they will have pacing when they do need it, with less chance of having, you know, pacemaker-induced cardiomyopathy. So one thing take away from here is just keep in mind, how do we optimize for the patient? What are the thresholds? Obviously, we leave our chronic settings 3.5 or our acute settings 3.5 until the leads become more stable. Is the patient dependent? At the time they were, but the next day they weren't. So you want to make sure that you have appropriate AV delays to allow intrinsic conduction to come across. So in this patient, for example, I just made sure the AV delays were long enough and then activated the VIP algorithm, because in the case, we didn't think they'd ever recover. And the next day they did. So you want to allow, for Abbott devices, they call it VIP. For Medtronic devices, it's called MVP. but it's like a hysteresis or it's an extension of the AV delay program by allowing the intrinsic to come across. So we reduce RV pacing in those cases. And then just to give you some snippets here, just remember to follow industry and manufacturer guidelines. This is an example of one of our Medtronic defibrillators. And obviously, Jules is our Medtronic expert. You could shed more light on this, but the out-of-the-box settings is this AX versus B vector. Medtronic actually wants B to AX moving forward. This, for people not in the know, is just your vector for your defibrillation. But it's something that's really important because there's actually been a warning from Medtronic out about it. So I think this is part of our concept that we need to have a template to guide people who are maybe not as experienced with complex tachy devices and things like that. So that at least you have some sort of guide and then you can customize it to the patient. I don't know if you have any input on that, Jules.
That's pretty much it. It is part of the new Medtronic advisory that all the tachy devices, the shock path should be changed to that B to AX. So B, that's your RV coil, and A is the active CAN, and X is the SVC. And that's so the shock path all have to be aligned that way. And that's so you said it, AJ, so that's right. Yeah.
Perfect. All right. So recap the future teams. We would advise bringing your lead, your scrubs, your shoes. Just because it's always good to have. They typically, everywhere we went, had shoes ready for us, but it's always helpful not to burden the local teams and everything like that. They have their own stuff to worry about without having to babysit, us coming in. So it's always nice to bring our own materials if we can. Extra accessories and implantables. Obviously, it's great to have everything on hand. And sometimes, you may have to just kind of roll with the punches. So it's good to have different things so you can put together different strategies for a patient, bringing meds, as we mentioned before, and then disposables and gowns. Prioritizing resources on hand. So keep in mind that if you're going to be seeing, 15, 20 implants in a week, you want to make sure that you're not burning all of your long RV leads on patients that could get by with a 52 cm lead, things like that. So being aware before you start this busy week of implants, what you have, so that you don't end up finding yourself shorthanded for the end. Everything worked out for us on this trip, but I could see had we not been able to acquire additional leads that Elvis and Dr. Dafe brought in from Port Harcourt, we could have been in some trouble as far as having systems that were well optimized for patients. Device selection is key. So just think about, what devices you have for a patient. If you have a patient that is 99 or 91 years old, maybe they don't get the longest battery that we have. If we have a younger patient who is going to be, susceptible for more generator changes throughout their life, maybe they'll get the newest device, so the strongest battery. Just things to keep in mind. Obviously, anytime you have a generator change, you double the risk of infection. So if you have a young patient, things to keep in mind there. Finally, maximize time of complex procedures, kind of what we mentioned before. We're always happy to help with dual chambers and ICDs, but these are things that staff can handle on their own. So it's, as we come in for trips, we want to make sure that we're doing the complex procedures. I think that's exactly what we did this trip. We had a ton of CRT, way more than we could handle at some points. So just for future trips as well, if we're going someplace that already knows how to do dual chamber pacemakers, they don't necessarily need us to tell them how to do a simple procedure. And it would, far be it for us to walk in and invade that space just to do a pacer. So optimize and maximize our usefulness or our utility when we're there. Finally, we want to thank all of our hosts. So Port Harcourt Cardiology, Dr. Dafe, was invaluable in helping us put this together. CardioCare in Abuja, Dr. Secco, his facility is fantastic, and we had a great time there. FCC Lagos. So Dr. Johnson, unfortunately, we didn't get a chance to meet up, but we really appreciate you hosting us. Dr. Incarno and Dr. Oladimeji from LASUTH met us out there in Lagos, and we did a number of procedures with them. And then the Healthy Heart Foundation, that is associated with FCC. They work to help supply indigent populations with devices and supports and help kind of defer the cost. And then obviously Pace4Life, I have to mention them as well. So Pace4Life, obviously, for putting this all together. Julius for coming out, Joel for all your hard work you've put into this. Tara, Alicia, who else we had, Dr. Timperley, and Stuart, it was great to have a senior Abbott guide as well, and kind of bounce our ideas off one another. So it was a really productive trip. As you can see, everyone enjoyed the lovely gifts, and the food was amazing. So I probably had way more food than I could ever handle. So I had a great time while I was there. Here's us in Lagos with Dr. Olameji, Dr. Seko here doing some work here with the dual chamber pacemaker. I think actually that might have been an ICD with Dr. Temperley. And that's the recap. I don't know, is anyone who was with us have anything to add or anything they would like to talk about?
Yes, AJ. Yeah, AJ, thank you very much. Wonderful, wonderful. Congratulations for the beautiful time in Nigeria. The little things I've been adding, but the little things I want to add again is, I remember on Wednesday, Miss Tara took the nurses on the working of the cath lab. So that was a very beautiful time. Miss Tara taught the nurses of CardioCare on the working of the cath lab. Then also, the local flights that we also took in Nigeria, they are well organized, and we must appreciate them, especially when the flight lands. We want to come out is row by row. You don't just rush. I think Julius really appreciates us for the discipline that we have in Nigeria on the issue of local flights. Then the hotels where we stay, the staffs were very good. I remember the first day you lost your wallet, and
you gotta come for me like this, okay?
And I said, AJ, I have never lost anything here. Let's go and look for that wallet. And we look for it. Julius Swim, you went to the gym, and you had some gym and some funds. Istara, Alicia, I think they went to the park to see some of the animals, some supermarkets, and the rest of them. In fact, a couple of things to mention. The teams have been so wonderful, simply very extraordinary. Stewards and the rest of the team, everybody very wonderful. In fact, we are meeting you guys here in Nigeria. So a great time and a great time. Then the other one I want to talk about is the issue of that patient that we took back to the cath lab the second time. So after the mission ended, there was no mortality throughout the mission. It must be commended and appreciated. There was no mortality on among the patients we work on, and there was no conversion because the mission is mainly on CROT. There was no conversion of CROT because of failed LV lead position. So after we took that patient back again to the cath lab, the patient returned back, and the mission ended. We started having the patient started having a lot of VT, and the device was actually shocking. I thought Dr. Seko would be here to mention something, but I messaged him, seemed that he's busy. So what we did, the fantastic team of CardioCare, what the fantastic team did was we all teamed together, myself, Dr. Seko, Dr. Wofisoye, we all teamed together, and we have to put this patient on lidocaine. So after multiple shock, the lidocaine was able to convert this patient. The reason being that one, that patient had heart STEMI. That was October 2022. And he had no coronary angio because there were no funds. He can't even pay for the use of the cath lab, even though when the procedure is free. So what we did for him is that we gave him a lidocaine, and we are speaking today, he's out of the VT. The myocardium is now quiet, and he's recovering, and is doing very well. So he's the only patient that remain in the hospital as we are speaking. Every other patient has been discharged, and all their wounds have healed. Even his own wound has also healed. The reason why we are still keeping him is that we want to observe and keep observing and seeing what the lidocaine effect is. Because after the lidocaine terminated the VT, we noticed that he had post VT post lidocaine complication, post medication complications. That was what we noticed in him. So we are still keeping him in the hospital, not because he had a VT again. His BP has come up. Before now, his BP went down. He went into cardiogenic shock. And he was having a BP of around 70, systolic 70, diastolic 30, 40 for almost 2 days, even despite all our medication to optimize the BP. And today the BP has stabilized, everything has normalized, and his wound has also healed. But we are now watching for the side effect of lidocaine to wane out before we discharge him from the hospital. So great job to CardioCare and the team of Pace4Life for all the good job that you have done. Thank you very much.
Thank you, Dr. Duffin. Thank you for mentioning Tara and Alicia as well. I'm sorry to leave you out of that week, the day we were in Lagos, the fantastic work you did training in Abuja. So
I was just going to add, actually, AJ, from a nursing perspective, some of the nurses sort of expressed an interest to become cath lab nurses. They were very interested in how the lab works, how it runs, how they can become cath lab nurses and scrub. So I will be sending them a lot of information. We use sort of competencies, training competencies for recovery and the cath lab. So I'm going to be sending them over. So hopefully they'll be able to utilize them and, you know, sort of be able to make up their own program, so to speak. I don't know how going forward, because obviously when we do it, we learn on the job, but if there's nobody there to teach them, that's slightly difficult. So that may be something to look at in the future.
Yeah, it's a good point. I think that, you know, having repeated trips, having a good cadence of these trips can help keep that information fresh in their mind, obviously, as well. So I think that obviously,
I'm very happy to go again. It was a brilliant experience. We were looked after very well. It was very, very good experience.
I think my only regret is that Julius never learned how to swim, unfortunately. So, Dr.
I think I showed it on a video that I wasn't too bad.
It's not proof enough for Adafe. He needs to further evaluate.
I'll take him on any day. We'll see him soon.
I think I muted you, by the way, Dr. Dafe, because there was a little bit of background. Was there anybody else? There you go.
I'm going to teach Julius on how to swim. I'm teaching on how to swim. Julius, you know that I'm from the riverine part of Nigeria. I'm from Bayelsa, who grew up in the water. So I will teach him on how to swim. But the other point we should also mention is, I remember talking with Dr. Timpley that we have a lot of variation in our anatomy. You know, sometimes when we go for the ID site, we notice that the vein is not actually on that ID site. So Dr. Timpley has also agreed that yes, that we have a lot of we have significant variation. I would say a lot, but we have significant variations in our anatomy. So one of the things we also learned in this mission is that when you puncture at the first read and you are not getting it, do an angiogram, and you may be shocked that the second read may be the ideal point for you to take your puncture. So, but all the same, I will teach Julius and Adrian how to swim in the next time.
Anytime, Dr. Daffy, anytime. Dr. Daffy, can you correct me if I'm wrong? So for any future missions, do you think you benefit from maybe having a temporary pacing wire kit, like a complete set? Because we came across a few patients in Harcourt who were really dependent, who might be sort of nearing battery change at some point.
Yes, you remember there was a patient we even interrogated in Port Harcourt who his battery is less than 1 year, and within the next 3 months we are going to change it. That patient will require a temporary pacemaker to do that because it's totally dependent on the device. So we can't have the second of split without pacing ongoing. Very important, very important.
Excellent. And can I add, I know everybody's been thanked, but can I also say a special thank you to Alicia as well for sending all the video diaries. They were absolutely fantastic, well appreciated, for keeping people back in the UK and America, across the world, abreast of all the things that were going on. You even added your own kind of style to it, which is like your favorite Nigerian like musicians, Afro beats, and that just added a kind of a little sort of taster to the whole video diary. So
thank you, Alicia. Thank you.
Oh, thank you. The nicest thing you've said to me, Julius.
I'm always nice to you.
At least this is recorded now.
Yeah, with proof.
Very good.
Yeah, thanks AJ for doing this. Really appreciate it. Thank you.
Thank you very much. You are a fantastic guy. Julius is now our ECG rabbi, a very great guy in ECG. If you have any ECG problem, send it to Julius, send it to the group so that Julius teaches us ECG. He's a great ECG rabbi of our time. So we really appreciate you for your insights, extraordinary insight into ECG. It's a phenomenon. Thank you very much for that.
Thank you.
I appreciate that, but I completely disagree. I appreciate that. Thank you.
Looks like, really quick, sorry to jump in. Looks like we have a hand raised. Someone named Samsung SM, which I don't think maybe is their real name. We have a question from the group.
Good evening. I am James Russell from Sierra Leone, an associate professor of medicine, and I'm currently the dean of clinical sciences. I joined recently this group, hoping that the timeline that was given was within the time frame that I was supposed to join. Unfortunately, in West Africa, we have variance in terms of our timeline. Having said that, I was introduced by a Sierra Leonean whose name basically I cannot remember, about the Pace4Life project, which is currently ongoing in Cameroon and Nigeria. So they asked me to join because we are doing similar projects with My Heart, Your Heart Foundation in the US, and I've been working with Professor Zaid Yusuf from Cardiff University. I don't know whether this meeting is about pacemaker related issues. I can see one of my Oga, my big boss, Dr. Oga, is also on this meeting. Thank you, and over to you.
Sorry, are you James Russell? Or...
Yes, I am James Russell. I'm James Russell.
So that was me that sent you the invite to come on this, to come and watch this.
Okay, yes.
Joel.
Oh.
Yeah. So my name is Julia. I spoke to Joel about you, and we basically, I mean, I'll let Joel speak more about it. He will tell you more about it. But yeah, sorry, Joel.
Yeah, just to say it's great to talk to you in person. I met Dr. Yusuf in Cardiff, and he told me about the program in Sierra Leone, and we work very closely with My Heart, Your Heart. I've just been out to visit them about 3 weeks ago, Thomas Crawford, Eric Purrell, and Brad. And yeah, we'd love to continue to help you. So perhaps we should set up a Zoom call all together with Julius, AJ, and everybody, and also with Thomas and Eric, and have a really great call about how we can help you in Sierra Leone. I know they've been out before. And so, yeah, let's have a call at some stage. And just as a straight first question, how would you like us to help you going forward? Would you like more devices? Would you like people to come out, like a mission like this? How can we help you?
Oh, well, that's a very good question, because I've been doing quite a lot of pacemaker implantation as a cardiologist, and apparently we've had a good number. I'm currently doing a study with Eric, as well as Dr. This chap from Michigan University. His name is completely. The line is bad. Hello. My line. The line. Yeah, Thomas.
Dr. Dafe, I think there's a lot of noise on your end.
Yes, there are lots of interference. I don't know whether the network is from my own part. So rightly been mentioned, of course, yes, we do have quite a lot of new as well as reused devices, and we have been doing quite a lot. But this is a discussion that we can have outside this meeting, especially in terms of helping out with devices, because from our end, a significant proportion of our patients definitely cannot afford to buy or to pay for the devices. So I welcome any suggestion, any questions or discussion that we might have in order to push the project here in Sierra Leone. Thank you, and over to you.
Well, perhaps first I could make the suggestion that AJ Hale, who is on the call here, is shortly to be full-time for pacemaker reconditioning and reprocessing across Africa. So maybe I can ask AJ to set up a call with you, if that's okay. And who has your number details?
That's perfectly okay.
Yeah. Do we have your details?
Yeah, I think Julius.
I've got it. Yeah.
Perfect.
Great. So maybe AJ and Julius, if you set up a call with him, and we'll invite Eric and Thomas, and yeah, we'll have a full call about exactly how we can help again, because I know they've been there, especially before lockdown. Eric and Thomas were there, so let's get going to help you out as much as we can. We've even got funding for a mission, so you know we can send people out exactly like this mission. We can do advanced devices. We can get you the iPad. We can get you defibrillators. We've got unlimited access to reconditioned pacemakers.
Oh, that will be fine, because yeah, that will be fine. I'm looking forward towards the discussion related to how best we can help from your end.
Fantastic. I will. Julius and I will circle back, put everybody into an email chain, and we'll get to work on that. So thanks for joining.
Wonderful.
Elvis, I see your hand raised. Did you have anything before we hop off the call?
Yeah. Good everyone. Hi AJ. Thanks for the nice presentation. I just want to say, express my gratitude to Pace4Life for this opportunity. It's been really a blessing to Nigeria and to Sub-Saharan Africa for the exchange of sharing of knowledge, experience, as well as tools to work with. Because you can read all the books you want to read. If you don't have the tools to work with, it's just an academic exercise. So I really appreciate the opportunity. And as a physiologist, I appreciate the learning that Pace4Life has really helped us to. I'm speaking for other colleagues too. Has really helped us to move on in our fields and to gain more experience. Thanks to everyone. It was really nice having you around. Thank you, AJ. Yeah, thanks.
Thanks, Elvis. I really appreciate it. And yeah, it was fantastic to be there, and we appreciate all the support on your end as well. It looks like Paisley.
Thank you.
Yes, hi, just a quick one from me. I'm going out with Pace in October to Nigeria, and I just wondered if it might be useful for myself and the other physiologist that's going out, Phil, to have a chat with yourself about stock that we need to get out there, just so that because we're hoping to kind of, well, we haven't really thought of that from far through, but we're hoping to go up to the back cave and see what there's there and get all the stock sent out ahead of time, so it can pre-clear customs and get it there before we get there. And just kind of from what you've said, there's bits that I wouldn't have even thought of about taking up. So I thought it might be quite useful if we can have a chat about that and see what things we should definitely be getting sent up there.
AJ, can I answer this?
Yeah, go for it.
Yeah. Yes, I spoke to Dr. Patel about this. He called me. So the person who was in charge of the logistics in terms of all the items that we were taking to Nigeria was actually Stuart. He wasn't able to come on today. So Dr. Patel was going to be calling Stuart later on to actually discuss this with him, because he's been to Joel's back cave and had a look. So he knows exactly all the stuff that you would need to take. And where we fell short as well, like AJ spoke about earlier on. So I think Dr. Patel is already going to be dealing with that with Stuart.
So he's kind of delegated it to me, I think, because he had a lot going on.
Right.
So he's asked me to try and sort it. Yeah, me and Phil, because we're the two physiologists going.
So do you want me to give, oh, sorry, go on.
Oh no, I would just say we could put together a call with maybe all of us together then.
Sure.
Jules, if you're available, and then obviously Stuart. Paisley, I'll just reach off. I don't know. Does anyone have your contact information? Don't feel free not to give it.
I'm on the WhatsApp group if that helps.
Okay. Awesome. Yeah, we'll reach out to you directly then, and we can go from there.
Perfect.
The only other thing to say, Paisley, is that the last sending of a box to Emmanuel and Michael took quite a long time to get there. So often it takes a couple of weeks, but there was a bit of a strike. So it took 2 months to get them out there. So it might be that we sort of, let's not delay too much. Once we've had a chat with Stuart, once we have a chat, and then Michael Olidimage is on the call here today. Once we've got a good idea of the sort of things, we have loads of PSA cables, we have a wide range of leads, we have a lot of things that have just been mentioned. So we can get a whole load in a box. But let's try and see if we can do it maybe 10 weeks before you go out, just so it safely gets there.
Okay.
Also, maybe as a question to AJ and Julius, would you say you probably had plenty of luggage space? And did you have any problems taking stuff out in your luggage?
Right.
Yeah, I would say sometimes carrying over. Sorry, Jules, I interrupted you, but sometimes carrying over is easier. In some way, I think most of what we used actually came out of bags we carried rather than we set ahead.
Spot on. Yeah.
And how did you manage to take leads out? Did you take, because that's a lot of weight to take.
Yeah. So Paisley, so each lead roughly weighs on about 7 kilograms. So everybody took their own lead coats. But what it was, I got stopped twice when we're flying back into the UK. It wasn't going out to Nigeria.
Okay.
And I had to explain what this thing is.
How did you do that?
So I was called. We've gone through check-in, everything's all done, security. We're just going to relax, start drinking coffee. Then I hear my name being mentioned on the tannoy, like, Julius Donko, come right there. So I went all the way down, almost to where the airplane was, where they were sorting out the luggages. And I had about 10 people surrounding me, like asking me, what is this thing? Yeah, and I had to explain to them. And they said that we've had about three boxes, like 3 luggages going with lead coats in them. And they were all flagging out, but we often let 3 go. And the 4th one, we had to really find out what it is. So I was called and I had to explain to them, and they said, thank you very much. So next time you come, we will know. And I told them that this is going to be repeated from the UK. Yeah. So I think they are maybe a little bit wiser about it now. So that should
they should know about it now. Okay.
Should know about it. And the other thing also, with regards to deeds of donation letter, which we normally get from My Heart, Your Heart, Repeal normally sends it. I think I spoke to Dr. Patel about this. So we had Eric print out a deed of donation just to say to Nigerian customs that we're carrying all these goods like devices and whatnot, because they get alarmed. They're like, what is this? What's going on? What's this? When we went there this time, nothing. Surprisingly, it was absolutely nothing.
Okay.
Nothing. But when I went there last year, oh my word, I had to.
Bit of a nightmare.
Yeah, it was a nightmare. So you never know who you're going to get, basically. But be prepared. You know, we can always get Eric to write you a deed of donation letter.
That's why we thought we'd try and get as much shipped out ahead of time as we could. But things like, those little bits we might have to make sure we've got all the stuff in place for that.
Yeah, spot on.
Yeah.
We've got an open invite to come up.
Thank you very much.
I would just get copies of the letter, put one in every suitcase you have, just so when they inspect it, they know what to look for there.
And who do we get that letter off? Is that from?
My hat, your hat, Eric Peel.
Yeah, the World Medical Relief is actually the one who printed it out for us. George, then I want to say his name. We'll get you in touch with him to get a.
Oh, perfect. Thank you.
That's through My Heart, Your Heart and World Medical Relief to get the letter there.
Okay.
And you can also ask Michael Ademeji to do a formal letter of invitation, which
we need that
also,
anyway for our visa, I think.
Yeah, so put that in with your stuff, and get visas early as well.
I was going to ask about visas as well. How was that process?
So I was I was going to speak to Dr. Patel about this. In fact, after this, he went off. The reason being, so I've been in touch with Dr. Johnson, Yemi Johnson, and I think there's going to be something done. So I've asked him to get all your names, and I'm going to forward it to him. I think he's actually going to meet a very important person tomorrow, and he's asked for the names. So I don't know what's going to be happening, but he's going to tell us exactly how we need to apply for it, just so that we can circumvent the issues that we had. Our mission. So he's going to find out exactly what's needed, how we need to apply, for it, and what's what, and that. So I try and obviously I'll let Dr. Patel let you know, or I'll ask. Can you drop your phone number for me, Paisley?
Yeah, I can. Do you want me to put it in the chat on here?
You can make it private.
Make it private. She's in the WhatsApp group.
It's on the WhatsApp. Her phone number's on the WhatsApp.
Oh, she's in the WhatsApp. Okay, let me get it. Let me get it just now.
Yeah, Dr. Olademeji, you had something?
Okay. Once again, I want to appreciate the Pace4Life group for the generous help they've given us in Nigeria. So regarding the questions raised regarding for the upcoming missions, so we can provide all necessary official documents that would facilitate your traveling across customs and across our NDLEA, which is the FDA of UK or US. So we have an official backing because we are Lagos State Teaching Hospital, so we are a government institution. So whatever documents you need to cross the customs or any officials at the airport, we have the backing of the government to give you all the necessary documents. So you just let us know, and who to address it to, we will be willing and very ready to do that. Thank you.
Perfect. All right. Well, if I don't see any other hands raised, if anyone has anything else, let us know. But thank you again to all of our friends in Nigeria for hosting us. It was a fantastic time, and we definitely are excited to get back there and get some work done. So appreciate it.
When are you going back next then?
Who, me? I don't know. October.
When should we go back to Emmanuel? We'll have to start planning, won't we?
Exactly. Yeah.
Yeah. Good stuff. Well done.
Thank you very much. Great. Thank you very much.
Thank you, everyone.
Thanks, AJ. Thank you.
Thank you, AJ. God bless you.
Bye, Elvis. Bye, Doctor.
Thank you.
Yeah, thank you. Yeah, good to have you.